Hello and welcome, everyone. We will start in just about a minute. Thank you for joining us today. Good afternoon, everyone, and welcome to our third session for Making the Healthcare System Work Better for You. I'm Rhonda Smith, the Executive Director of the California Black Health Network, and today's session is on the topic of navigating the healthcare system. And I'm sure we all have our own personal story about what that experience has been like for us and our loved ones. So the question of the day is, how do we do that in a way that does make the healthcare system work better for us? You know, we're very fortunate to have the opportunity to partner with the California Healthcare Foundation to provide the answer to this question and more. This partnership really enables us to elevate health education and health literacy through the How Do I campaign, which is an initiative to provide the knowledge, skills, tools, and resources to empower Black Californians to take charge of their health and healthcare and really own their power when interacting with the healthcare system. The How Do I campaign was evolved from one of the recommendations that came out of the Healthcare Foundation's Listening to Black Californians research, a project to really understand what happens to Black Californians when they interact with the healthcare system and what that experience is like for them. So we want to make sure that we at the California Black Health Network are doing our part and through our work with the How Do I campaign to help our community know how to navigate this complex healthcare system so that we all are seen and heard, ensure that we get the care we need and so deserve, and make sure that the healthcare system really can be more responsive to our needs. And so once again, we are delighted to have as our subject matter expert, Dr. Glenda Newell-Harris, who is the co-author of Focused on Your Best Health, the Smart Guide to Healthcare, the Healthcare You Deserve. The book was created to teach healthcare consumers about how to communicate, navigate, and advocate for themselves when they interact with the healthcare system. Right, before we hear from Dr. Glenda, just a few housekeeping items. Once we hear from her, we'll have a Q&A, so you'll have an opportunity to ask questions. So please put your questions in the Q&A box. If you want to say hello to someone you recognize who's in the virtual room today, or share your thoughts as you're hearing what Dr. Glenda is going to be talking about to us today, please feel free to put that in the chat. Everyone, as per usual, will remain muted and off camera for the duration of the webinar. And so before I bring Dr. Glenda on, just want to spend just a couple of minutes giving an overview of the California Black Health Network for those of you who may not be familiar with who we are. Next slide, please. Yeah, so the California Black Health Network is a 40-plus-year-old organization, and we are the voice and trusted resource for Black health equity in California, and the only Black-led statewide organization, I say, that works for all Black Californians in advancing health equity. Next. So what we do is outreach, education, advocacy, and policy work, as well as programmatic work to advance health equity for Black Californians. And we do that through the lens of understanding the dynamics at the intersection of racial justice, social justice, and environmental justice. Next slide, please. And so our vision really was born out of what was happening in the summer of 2020, because we really needed to focus on some of the key issues impacting our community. But we are working to envision and create a California where every African-American and Black immigrant has the opportunity to live a long, healthy life free from violence, racism, and health inequities. And we work to do that every day through our mission, which is to ensure that all Black Californians, regardless of who they love, where they live, how well educated they are, how much money they make, how they identify, or even their housing status and where they're from, has the opportunity to access quality, high quality, equitable behavioral health and primary care, and definitely not succumb to diseases that are preventable and do that unnecessarily. Next slide, please. And so I'm happy to once again bring to you Dr. Glenda Newell-Harris, who is a distinguished physician, author, speaker, and patient advocate with a career spanning decades. Dr. Glenda, as we affectionately call her, has been at the forefront of addressing health disparities and being a champion for equal access to high quality healthcare for all. She has been providing healthcare to diverse and underrepresented populations for the majority of her career. She is a physician leader in internal medicine and a trusted voice and go-to expert for her patients, family, friends, and communities around the world. She educates on issues around healthcare and health advocacy, and her mission is to empower those individuals that she's helping. And that stems from being on both sides of the doctor-patient relationship and sharing her own experiences sometimes, and from living an extraordinary life experience. So Dr. Glenda received her BS degree in biology from Tufts University in Massachusetts. She received her medical degree from the University of Cincinnati School of Medicine. And I think one of the most important things to mention about her, in addition to all her accomplishments, is one that is most significant, and I think that she feels the most honored about, is being appointed by President Biden to serve on the advisory committee for the Office of Minority Health. She currently resides in Oakland, and I won't say much more about her, but I think you get the gist of who she is and what she's all about. So I'll turn it over to you, Dr. Glenda, to share your words for today.
Thank you so much, Rhonda, for that very gracious and generous introduction. Good afternoon, everyone. It is so exciting to be back with you again to share a little bit more information with you today about how to make your health encounters be the best. Today, we are going to focus on navigate. And as you know, navigate means to get from one place to another. And so the complex thing about today is going to be, we're going to be talking to you about how to get from one place to another while you're sick. And that's one of the things you've got to always be thinking about. You're doing this navigation while you're actually somewhat compromised. So let's go to the next slide. But before we get into navigation, let's just recap very, very briefly about some of the things that we've already talked about. We had a wonderful session, I thought, about patient rights. And so during that time, we talked about the choices of providers, emergency care, how you are expected to be involved in treatment decisions, how are you to be respected in your visits with your providers, the importance of confidentiality, and more. And then when we talked about communication, I just listed just a few things here that we addressed, and that is the different aspects of effective communication. There's verbal communication, nonverbal communication, active listening, and written electronic communication. I wonder if there are any that are listening here today that have actually had some health encounters since our last visit and had an opportunity to either watch this with your own providers or even check yourself and see if you were actively listening to the information that your providers were giving you. So let's move on to the next. Understanding the healthcare landscape. So we're going to talk very, very briefly here about health plans. Now, if you're like me and many of my colleagues and friends, you may work for a company that changes your health plan often every year or every couple of years. And as I have said before, it used to be back in the old days that when you had a healthcare decision to make, someone would come to the office and they'd sit down with you and they'd go over the different aspects of the plans, and they'd let you know which one was more expensive or less expensive, or which worked for a family of 5, or which one was better for a single person. But that hasn't been happening now for quite a few years. Now they basically send it to you electronically, and you're supposed to sit there and figure it out. They're grids and they lay everything all one next to another. But for many of us, sometimes that can be very complex. So when you're looking at a health plan, there are things that are called benefits. There are things that are called networks, and there are costs. So the benefits are the things that the plan will offer. Almost all of our plans now will offer preventive care, but short of that, you may be paying for some other aspects of your benefits. Networks, you will hear the term in-network and out-of-network. I encourage you, as much as possible, try to stay in-network. You will decrease your out-of-pocket cost if you will do your best to identify providers that stay in network. And you might say, well, how do I do that? Well, usually your network is dependent upon who your primary care doctor is. So if you're seeing providers that are generally referred by your primary care doctor, you're likely to be working within that network. But you want to ask that question because, again, it will keep your out-of-pocket costs to a minimum. And then cost. You will not get out of healthcare insurance without paying. I promise you. Some of you may be fortunate enough that your companies are paying the whole thing. And if you've got a company like that, you better kiss them and stay right there, because not many people do that. Companies are paying a portion of your premiums, and then you are paying a portion of your premiums. And then after you do that, you are generally paying some sort of deductible. And that can be anywhere from $1,000 to $5,000. Depends upon what you pick. And then there are things called copays, and that's what you pay when you go to the doctor. And sometimes it's more for a specialist or more for an emergency room visit than it is for a primary care doctor. And then there's something called co-insurance, and that is the percent that you will pay after your insurance has paid, and that varies, but many times that's about 20%. And then there are other things that we didn't list here, but there are things called allowable amounts. You will see that on an explanation of benefits. And you might say, what's an EOB? What's an explanation of benefit? Well, it's a piece of paper that comes to you from your health insurance company, and it lets you know what you were charged, what they have agreed to pay, what you're going to pay, and then it will list all of your other things. So when those EOBs come, if you don't have time to look at them, create a folder and stack them away, because when the bills start coming, you want to be able to understand what you're really required to pay. Next slide. Then we want to talk a little bit about things called PPOs and HMOs. Now, most of you, I'm sure, really understand this already, but depending upon your plan, you will be in a PPO or an HMO. Now, all plans, you need a primary care doctor, but with a PPO, it's not required. That's a preferred provider plan versus a health maintenance organization. Referral required to see a specialist. I know I have a lot of friends that say, well, I don't need a primary care doctor to refer me to a dermatologist or a pulmonary doctor. And that is true when you have a PPO. But I will just caution you to say, it's always really good to have somebody minding the store. So if you pick up and decide to go to cardiology or go to dermatology or go to rheumatology or go to pulmonologist, and there's nobody that really is minding the store to kind of keep things coordinated, then that's going to become your responsibility. So be careful with that. It's great that you have that liberty to be able to do that, but just know that somebody's got to be able to keep all these things together. With an HMO, you generally do need a referral in order to be able to see a specialist. I've already talked about in-network benefits, and that works for both. And then non-emergency, out-of-network benefits. That is available to you through a PPO, but generally everything is supposed to be managed through the HMO. And then emergency coverage is you can get with both, obviously with both plans. Next slide. Setting yourself up. Yes, setting yourself up for success. So in order to successfully navigate most healthcare systems, you must be able to do a few things really, really well. The first thing I have listed here is selecting the right doctor. that's really your initial point of contact. And if there are any on this call today that do not have a primary care doctor, that is the first assignment that you need to write down and create for yourself. I know if you have an OBGYN doctor and you're going there, you feel like that's your primary. And if that person is owning and accepting that responsibility, then fine. Many of you may be seeing a cardiologist, or you just go see a dermatologist, but everybody on this call needs a primary care doctor, and you need one for yourself and your family. Secondly, you need to know when to seek urgent care. We'll talk a little bit about that toward the end of the presentation, but it is very important that you seek urgent care at the proper time. In other words, you don't want to go to an urgent care facility to be seen for something that you could have been seen in your primary care doctor's office. Often when you don't have a primary care doctor, then individuals tend to use urgent care facilities and emergency rooms as their primary point of contact. And that's really not the best way for you to get care. Thus, the importance of selecting the right doctor and a primary care doctor. And then, of course, third, but most importantly, also choose the best insurance plan for your healthcare needs. And that's really going to depend on your own medical challenges or your family's challenges. If everybody's healthy and well and nobody's on medications, then you can maybe choose one kind of plan with one type of premium. But if you know that there are chronic illnesses in your family, you may want to take a look at another type of plan. So choosing your own insurance, the insurance from the options that you have, this is not something that you want to kind of make a quick decision about. You want to sit down and go through that a few nights in the evening with your family and really think about what's going to be the best thing to work things out for you. Next slide. Selecting the right doctor. I've already mentioned that a primary care physician is your initial point of contact. So you might say, well, how do I find somebody? Well, I will tell you, and I've told you this before, the best referral for another doctor is from another patient. Now, as physicians, we often refer you to various doctors, but I have to tell you, as a physician and as a patient, there's nothing like a patient referral. I know my doctor colleagues as doctors, but unless I see them as a patient, I don't really know how they engage. I don't really know if they follow up. I don't really know if they sit down and listen to you. They listen to me because it's a professional colleague experience. So I say, talk to your friends. They are the best referrals for a primary care provider. You can also go online and read some of the comments that people write. Now, keep in mind, most people rarely go online and say something wonderful about a doctor, a restaurant, a hotel, you name it. But we are very quick to go in and put in comments when things don't go well. So I ask you to be careful when you're doing online searches and looking at reviews. That's just one piece of information that you want to consider when you're trying to select a doctor. And then, of course, the concept of in-network and out-of-network. If you already have a doctor that you really, really like for a specialty area, and you're now deciding to want to put it all together with a primary care doctor, you may want to go and say, oh, wait a minute, is there a primary care doctor that's in this network already? Because I want to stay in this network. Like I said, this is navigating healthcare. It's complicated, but I know you can do it. And with this information, you're going to be able to coordinate it and put it all together in a way that's going to work best for you from a medical perspective, from a financial perspective, from a logistics perspective, and also from a convenience perspective. You don't want to have a doctor that's down in Palo Alto and you live in Oakland, or you don't want to have a doctor that's in Sacramento and you live in Roseville. So the proximity of your providers is important as well. And then there's something really new called concierge medicine. That's something relatively new that primary care doctors have decided to elect as part of a way to practice medicine. And concierge physicians are generally physicians that are in the area of family practice or internal medicine, and they make a decision to only have a finite amount of patients. And you pay a certain amount of money to be their patient, sort of like being on retainer. And then they're available to you. Some people love this. They really feel like it's giving them that special care, like, how things used to be, years and years ago. So that's another, and some people will be in a network, and then they'll also have a concierge medicine doctor. It depends upon your pocketbook. A lot of people just want to feel like they've got a doctor they can pick up and call, and they will answer the phone, not necessarily the assistant. Vetting your doctor. We talked a little bit about doing that online, but I also really think the best place to try to vet your doctor is with other patients. Next slide. Why is it so hard to find, and I'm going to take away the good part and say a primary care physician. I think sometimes you might feel that it's tough to find a good any kind of doctor because of all of the challenges that doctors are being faced with. But let's just talk a little bit about the primary care doctor, because that's a very, very important person in your armamentarium of caring for yourself. Well, first of all, primary care doctors are the lowest paid of all of the professions. And when I talk about primary care doctors, I'm talking about people that are internal medicine, family practice, and I'm going to include the pediatricians. I am a lover of children. As many of you know, I am a very proud grandmother, and I loved my pediatrician when my children were young. And if there are any of you that have children, you know that you would probably give up your own doctor's appointment to take your child to the doctor. And it's unbelievable. Pediatricians, internal medicine, family medicine, we're at the bottom of the pay scale. There's also a very, very high rate of burnout, because these doctors are being called for everything. They're called if the baby diaper is dry too long. They're called if there's nausea or vomiting with an adult. They'll call if there's constipation with an adult. You get a call if there's abdominal pain. You get a call if there's chest pain, ear pain. As an internal medicine doctor, we cover you from head to toe. And therefore, we accept phone calls from head to toe, where alternatively, a cardiologist isn't going to take a call from you about nausea, vomiting. They only want to hear about the heart. A pulmonologist is not going to want to really hear about the heart. They may, but they really want to know about your breathing. So in internal medicine, family practice, these are some of the things that sort of burn doctors out, make them just feel that they can't provide quality care to anybody because the phone's constantly ringing. There are competing professions now for young people coming out. As I said, years back, it was, be a teacher, be a lawyer, be a doctor. But now there's so many more professions that young people can go into that, many of them say, ooh, 4 years of medical school and 3 years of training. Are you kidding? I can do 2 years of an MBA and come out making twice what you're making. And it's true. It's happening. So going into medicine, I feel, has got to be a passion or a ministry. You've got to love it, because if you do, then, you do make money, but, you're making it in a different kind of way. And you just can't compare yourself with somebody that's possibly working for a company where they're getting big bonuses. It doesn't happen in healthcare. I'll tell you, maybe in some health corporate programs, but I have to tell you, I've not been in a program in my career caring for patients where any type of bonus has ever been offered. But it's okay. I love what I do. And then the cost of medical school. I mean, medical students now walk out of medical school with debts of $200,000. And that's before they've purchased a home, or before they've even thought about the need to send their child maybe to a private kindergarten. So that's a significant obstacle for someone wanting to go into medicine. And then, of course, we have and we have for many, many years, which adds to the already complicated problems. Next slide. How do you tell your doctor that you want a second opinion? I know many of you have asked this question. So I'm going to give you a few concrete things here. And this, again, is navigation. You're in the doctor's office. The doctor has shared some information with you, and you're sitting there trying to figure out, is this real? Well, I was perfectly healthy like a month ago. How did all this come about? Can I trust what he or she is saying? And then, of course, you've probably Googled it already, but these are some reasons why people do seek second opinions. One, it's a diagnosis that's rare, or the symptoms are not consistent with the biopsy interpretation. And a biopsy is when you take a chunk of tissue and you slice it up in teeny pieces, and you put it under the microscope, and it tells you a lot about what's going on in that part of the body. Thirdly, the original pathology report may be inconclusive. And you say, well, what's that mean? Well, that's when it's kind of like a come see, come saw, and you're thinking, oh no, there's not going to be any come see, come saw with my healthcare. It's either black or white or up or down. And I don't blame you. I don't want any come see, come saw with mine either. But there are times when the pathologist gets information under that slide and it just doesn't fit in a perfect box. So sometimes you might say, well, let's send the slides to another institution and let the slides be looked at. So that's really not a second opinion doctor, but that could be a second opinion of your review of your slides. And that can be done as well. Another reason for seeking a second opinion is there's no family history of hereditary disease such as that. I mean, there's so many people now that are contracting medical problems, and they're looking to their right and their left to figure out, well, who in the family has this? And there are no answers. So there are many things I am personally beginning to feel that are in the environment, and we'll know maybe in 50 years. But nevertheless, when those conditions come to you, you must address them. And in many situations, you want to address them quickly. Or another reason is you just don't feel comfortable with the diagnosis. When we get those diagnoses that we know are going to be lifelong, and you've been living for a certain period of time and it's never happened, you just, first of all, it takes time for you to process things like that. So don't be surprised when you walk into the doctor's office and the doctor hits you with, you've got rheumatoid arthritis. Well, you've had a little ache here and a little ache there, and this joint's been off and that joint's been off. But that whole word rheumatoid arthritis means a whole nother thing, because it comes with a slightly different set of conditions, so to speak. So don't feel that you are in some ways being difficult or out of the ordinary. It takes time to process a medical diagnosis that is given to you. Give yourself the time to do that. Don't rush the process. I promise you, over days, you will be able to understand it better and welcome it better and say, okay, that's what I've got. Well, you know what? I'm going to continue to live. So what do I need to do to manage this condition? Next slide. Firing your doctor. Now, this one's is a little, we want to be a little careful with this. First of all, I've already told you there's a shortage of doctors. So you do really want to be careful if you want to step out there and decide, I'm firing my doctor. I've had an absolute enough. So the first thing I want to say to you is, first of all, take a look in the mirror. What did you do in that doctor's appointment that may have made the situation not be comfortable? Have you been one of those individuals that may have missed multiple appointments and then you're finally there? Are you one of those individuals that just has not had the time to go get those labs done, and then the doctor's just standing there like, oh, you didn't get a chance to do it yet, Mrs. Jones or Mrs. Smith? So the first thing you want to do is take a look at yourself, make sure you're in the right frame of mind. Have you carried your piece of this responsibility in all sincerity? Have you? And if you can say yes to that, but then you look up and you say that your doctor has a lack of sensitivity or empathy to you as a person, if you feel that they are rude or condescending in their communication with you, or if you feel that their arrogance, now, all of us have some aspect of arrogance, though I think doctors kind of take the cake. They embarrass me sometimes. I love it when people say, oh, you're a doctor? We didn't know that. Highest compliment you could ever pay me. Because sometimes I feel my colleagues walk in and they've got doctor, exploding from their chests, their name badges. And of course, yes, I work very hard for this degree and I love it. And I like to be identified that way. But you know what? We all got to pay taxes, and we all got issues, and we've all got family members that act crazy. So nothing about my MD degree is going to change that. So that's just my personal feeling about arrogance. But there, I have to also say there's a positive side about arrogance. I sort of like seeing doctors that are so, if they're mine, that are so confident about their situation that there leaves no doubt in my mind. So I think arrogance has a balance to it. But you know what I mean in terms of these things that are sort of intangible things. So you want to be sort of careful about letting a one-off make you make that decision to fire. Now, on the other hand, these are some other things that I think are more specific. If they've missed a diagnosis, or they fail to respect your time, or they continue to use medical jargon and you've asked them over and over to not to do that, as though you're feeling that they're trying to, keep you out of the loop with your own health care. They're never available. Or again, they're consistently rude, or their staff is consistently rude. These are some of the things that I think would make you want to say, gee, do I want to continue to stay in this office? I do have one story I can tell you about a good friend who actually felt a lump in her breast. And as she tells the story, she went to the doctor and the doctor identified that, yes, it was. And then the patient went to get a mammogram. And as the story goes, the mammogram was negative. And the return back to the doctor visit, as the story was told, was that the doctor said, well, it must be something you just don't need to worry about. And of course, the patient was very uncomfortable with that, sought another doctor, found out that, yes, it was mammogram did miss the lump, because let me tell you, no tests are 100%. Now, that's kind of a strange story that you can feel a lump and then you go in and the mammogram doesn't pick it up. So believe your fingers, believe when you feel something, if it's really there, just keep asking. And in this particular case, this young lady ended up with breast cancer. And I'm happy to report that she had the problem addressed. She went on to have surgery and the necessary treatment, and she's alive and well today and living and doing extremely well. But she made a decision that she didn't want to go back to that doctor. Next slide. But firing can go both ways. Your doctor might fire you for disrespectful and rude behavior, repeated no-shows and last-minute cancellations of appointments, a failure to follow treatment plans, a non-compliance with medications, testing, and procedures. Let me tell you a little bit about surgeons. I have some in my family and I've had some experiences with them. And one of the things that I did not remember about medical school is surgeons do not like complications. That sort of messes with their statistics. They also don't like infections as a result of anything they have done. So when surgeons now see patients, they often offer to the patient, if they're going to operate on you, well, my infection rate, is 0.1%, and my complication rate for the last 10 years has been, 1% or, 1.2%. Well, you play a significant role in that. So if the doctor sends you home from a procedure and tells you not to do things and you do them, what do you think is going to happen? Then you start having complications. Then you start having infections. Then you have to get more medication. Then the doctor has to list that as a complication. Now, things do happen. Things happen in the operating room. Things happen in the hospital. But there's something, I had a friend to say to me once, Glenda, try to be as good a patient as you are a doctor. And, that was a wake-up call for me, because I try to be a good doctor. But, I have to tell you, I'm not 100% all the time when I get instructions, but I have learned from watching and listening that there are certain things that you just really need to take a, pause. And if the doctor tells you don't do this for some period of time, or I caution you to remove that from your diet, or, nobody's going to police you. But the things that you're being asked to do are things to really help you and benefit you. And if the doctor can find out that you are overtly not doing that, they don't really want you as a patient. So you could be fired for not following through on the doctor's recommendations. Next slide. in the hospital. So if you have that situation that requires you to have to go into the hospital, you may be engaged with something called a hospitalist. And if there are those of you that were hospitalized before 1995, you probably didn't have any experience with these individuals. But a doctor by the name of Dr. Robert Wachter and Dr. Lee Goldman coined the term hospitalist in August of 1996. These are doctors that are generally trained in internal medicine, pediatrics, or even family medicine, and they are there to care for you in the hospital. And you might say, well, what happened to my real doctor? Where is my primary care doctor? Well, this was really being done. This whole concept of hospitalist, I believe, was created in an effort to be able to give you better care while you're in the hospital. If any of you have ever been hospitalized before 1995, you may notice that your doctor would slide through in the morning about 8 o'clock, and then maybe they'd slide through at 5:30. But think about all that running around for your doctor. And then they have to go to the office and then see the 35 or 40 patients that were there from 8 to 5. This way, you have a doctor that is on site in the building all day, 8 to 5. Then there's a night crew that comes. So when you're having urgent needs, there's somebody right there that can handle those needs. Now, your own personal doctor may elect to come and visit you in the hospital and check in, but generally that care is provided by the hospitalist. In addition, when you go to the hospital, bring your own personal health record, whatever you have. If it's something about your immunizations or if it's something about your medications, bring that with you when you come. The more information that you can bring to share, the better off. However, if you are going to an in-network hospital, guess what? When they open up the electronic medical record, all your stuff is there. So that's another reason that, staying in network can be helpful. What should you do if the doctor says that you are to be admitted? Well, first of all, accept it, process it, and, understand that whatever that party was tomorrow night, you're not going. It's okay. There'll be one in 3 weeks. You can go to that one. But make sure that you notify your primary care doctor the next business day so that they can know that you are there. And many times your primary care doctor will connect with the hospitalist and provide them with information that they think is helpful, or they may even come and visit you while you're there in the hospital. Next slide. Discharge planning and care. So when your hospitalization and your acute situation is over, it's time to go home. So again, you want to follow the directions of the doctor so you're not a bounce back to the hospital. And so as part of that, you may be asked to go to rehabilitation, which would be physical therapy, occupational therapy, and speech. Keep those appointments. I have to tell you, I prescribed physical therapy for probably 30 years. And then I had a little knee injury and somebody recommended PT for me. And I said, oh yeah, wonder if I'm going to do that. I decided to go. And it really was helpful. Of course, this happened to me right with COVID. So I only got about 2 or 3 visits before we were all put on lockdown. But I really did find those experiences with PT very helpful. Secondly, you will be given medication. It is very important that you either get your medication before you leave the hospital, or you plan that whoever is picking you up from the hospital, that they swing by a pharmacy and get your medication. Be sure to talk with your doctor before you leave the hospital about what medications you are being given and why. Why are you being given these medications? You should never walk away and say, well, I don't know, I got these 5 bottles of something he or she told me to take. Well, why are you taking this, antibiotic, Mr. Jones? I don't know. That's just that should not be you. You want to know why each and every pill is being prescribed. And you also want to know, do I take them until they're all gone? Or should I be just taking these on an as needed basis if I have pain or if I have constipation, things like that. And then who pays regarding these discharge planning things? It will vary. But if you're being discharged from the hospital, generally your insurance company will pay for your medications. And when you are being transferred to a rehab, they do all kinds of checks and balances before they find out whether it's covered. Because I promise you, a rehab facility is not going to take you unless your insurance company has already told them how many days of rehab that they will allow you to be there, that they will cover. Next slide. Now, this is a little secret I'm going to share with you here on this slide, and this is my opinion. This is not anything you'll find in JAMA. You won't find it in the Annals of Internal Medicine. You won't likely find this anywhere, but I often say to folks that I work with when I'm coaching them is, if you need elective surgery, try not to do it in July. And you might say, why? Well, this really only applies if you are going to a hospital that's a teaching hospital. And that's because all of the residents and interns turn over on July 1st. Some turn over on the 25th of June. So this is kind of a joke, but it's really not a joke. I know when my parents have gone into the hospital and they were in teaching facilities, I remember my father used to say, I'm tired of talking to all those people. Can't you go back and talk to the last person? I told them the same. They asked me the same questions. Why can't you get it? And the poor medical student, who is generally the last person to get to the room, because you got a senior resident, you got a junior resident, you've got a fourth year student, an intern, a fourth year student. And then by the time the poor third year students gets there, you're exhausted from telling the story over and over. So just be careful. If you need surgery in July, by all means, go get your surgery. But if it's a knee replacement, you may want to decide to push it up into August, unless you have a job that's off in the summer and it makes more sense for you to get it done in July. So, but if you find yourself in a situation where you're in a hospital and it's a teaching hospital and there are many training staff, just find out who you're talking to. You may be getting instructions from who you think is the attending, but it may be the third year medical student, because these medical students that come out, they're pretty sophisticated. So you just want to know. Next slide. Tips for scheduling medical appointments. These are just a few tips of things that I wanted to share with you when you're getting ready to schedule your appointment. Gather all your documents. It's really best if you can do it online. It just gives you that flexibility. You see what the appointments are. You don't have to go back and forth. Bring your own calendar. So when you're booking the appointments, you know that, the timing will work. Determine before you decide to make the appointment, what are you going to put in the reason field of your medical problem? The doctor doesn't need a paragraph, just a couple of things. And it's also very, very helpful to say how long it's been going on. 2 weeks, 2 days, a month, a year. That's very important. Know your availability. As I said, bring your own calendar. Be aware of your financial obligations. When you go to the emergency room, I promise you, your copay is going to be a lot more than it is when you go to your doctor's office. But of course, there's not a big difference between between $25 and $50 and $100. But just beware of your financial obligations, and also beware of the financial obligations of things that you will pay for seeing a provider in an emergency room versus seeing him in a private doctor's office. Update your personal health record, bring it with you, have it with you when you're booking that appointment in case they ask you questions, and then keep and value your regular appointments. We're almost at the end. Next slide. Visiting the emergency room. This is an extremely important aspect of what's going to happen to you in life. Because if you live long enough, you're going to have things that are going to happen to you that make you feel like you have to go to the emergency room. And so going to the emergency room should be for things like shortness of breath, uncontrollable bleeding, chest pain that's different from your usual, loss of consciousness, head injuries, severe abdominal pain that's very, very different from before. Take an advocate with you. What's an advocate? Somebody that's your buddy, your friend, somebody that's not sick, somebody that can speak for you, somebody that can talk to the doctor and tell them a little bit about you when you are just so stressed, so anxious, so tearful, you just can't get the information out. Do not go to the emergency room by yourself. It is so important that you take someone. And we'll talk a little bit more about this when we do advocacy. Next. Pay attention to the procedures and treatments that your doctors order for you. We as physicians are so quick to write CT scan of the abdomen, MRI of the breasts, ultrasound of the abdomen. Well, you may not know what an MRI is. Ask the doctor, what is an MRI? Can you tell me what that entails? Doctor, how long am I going to be at this appointment? So in case you don't know, an MRI is a test that puts you in a machine And if you have issues with claustrophobia, well, you're going to have a problem. But we can work around that. But you just need to know if you're going for a test and they put you on a special kind of table and you're turned, upside down or to the side, you want to know that. You want to be prepared. So you want to know, what is the test? You want to know, what is the test looking for? What are the side effects of the test, if any? If you have to get an injection, you want to know, do I need to worry about that? What are my options and alternatives in this? And the doctor may say, well, there's no other way we can evaluate this problem without this. So you really want to ask as many questions as you can. And I know how it is. It's scary. And so sometimes you're like, well, maybe what I don't know won't hurt me, but you just want to be prepared. You want to know whether you're going to be in and out or whether it's going to procedure that's going to take you, an hour, just so that you can plan. Next slide. So our wrap up for today: how to evaluate the different types of healthcare plans, the importance of selecting the right PCP for your needs, even if it's a second opinion, the key aspects of health insurance, benefits, premiums, deductibles, copays, and coinsurance, and then what happens during and after a hospital or emergency room visit. Next slide. That ends our presentation for today. And I hope that I really was doing my best today to try to end this with enough time. I was noticing, even though it's hard for me to present to you and read the chat, but I had noticed over the last few sessions, people were like, oh, I gotta go. And so I was telling Rhonda, I said, I gotta move more efficiently so that we can get a few Q&As in before the hour is up, because I know many of you are on your lunch hour. So thank you for the opportunity. I'm ready now for a question.
Yes. Thank you so much, Dr. Glenda. As always, you always share so much valuable information. And so hopefully those that are in the audience today can take something and actually act on it the next time either they go to the ER or to their doctor appointment. And so I do have a few questions in the Q&A box, and we'll see if there are any in the chat. But the first question is, when your loved one is placed in a care facility under the term hospice, what care is required, or I guess rendered to that patient?
So that's a great question. I'm really glad that this was brought up here because, the studies show that people of color tend to wait to get hospice care when really the family member really has about 2 or 3 more days left. It's just, we wait. But hospice care can be available to you for 364 days, is my understanding. I've not worked in hospice, but I have close friends that do. And then some patients actually get dismissed from hospice, and then they can be readmitted. But it varies. There is not a cookie cutter answer for what kind of care that you get in hospice. And it just really depends upon the patient. Generally, when patients are in hospice, it's determined that the patient has a terminal condition that is not likely to get better. But patients are to be given nutrition, they are to receive pain medication. Sometimes decisions are made between the family and the doctor that if the patient gets an infection, depending upon the state and the status of the patient, sometimes the family will say, well, I don't want you to treat an infection. But other times they'll say, well, look, if you can just give my loved one an antibiotic to treat a urinary tract infection, that can happen. So for every single case is different.
Okay, great. Thank you. The next question is, how does insurance work when you're getting a second opinion?
Great question. I'm recommending that you speak with your every single insurance company is different. I will say that I did work for Kaiser for a period of time, and I can tell you that Kaiser offers second opinions and there are no issues. What they generally will do is you will, if you're being seen, now this is a few years ago, things could have changed, but if you are a primary patient in Oakland, then they may assign you to go see someone in the San Mateo area, something like that. And you do want to get a doctor that's not right in the office of your other doctor, because you kind of, unless you're being open with your doctor that you're getting a second opinion. But sometimes they're covered. And I actually think I read somewhere that Medicare might pay for a second opinion too, but you want to check on it first.
Great. And So some people want to know if they can get a copy of the video. Yes, so the video recording of this webinar will be on our website, and we will also send out information after the after the webinar is over about that. So yes, you will be able to see Dr. Glenda's slides and the recording and actually view the recording. And so the next question is, do hospitalists share your in-hospital treatment info with your PCP?
They can, and that is why it is so important that you notify your PCP that you are in the hospital. I mean, all of the, if it's within the same network, your doctor may be able to actually from their office pull up the information, but all that information should be shared. There are no secrets as far as that's concerned. In fact, your primary care doctor needs to know as much as possible because you're going back to the primary for your follow-up care.
Great. And then the next question is, how can you best help a loved one with dementia navigate the healthcare system? That's an interesting question.
Yeah, that is a great question. And you know, more and more of us, and I just say people, I'm not saying any particular race or any particular gender, but I'm just getting more and more information about people having family members. You know, I'll say a couple of things. First of all, I think I want to say make sure that your family member is in an environment where they're getting the best care. I have a friend who has a family member that is challenged with some of these matters right now. And a decision was made to have that family member go be seen, here we go, at a teaching hospital. So, you know, I tell you there are good things about it, and I tell you there are challenging things. And I am telling you that this loved one, after going to a teaching facility where this facility was very, very experienced in dealing with Alzheimer's, those types of problems, they made changes in that loved one's medication. And I talk to my friend all the time, and she is so pleased with the difference. The family member still has memory issues, but she is able to engage so much more with her family, and her quality of life has really changed from that perspective, as has the family that's taking care of her. So that's one thing. But the second thing is, it's important for you to try to develop a cadre of support members to help you, because you cannot do it by yourself. Nobody cares about the caregiver. Everybody calls and wants to know how Grandma Sue is doing, but nobody wants to know how the daughter Mary is doing, who has been taking care of Grandma Sue for weeks. And I know I'm talking to some of you because I have an elderly mother too, and I've had to take my own pulse. Glenda, what are you doing to take care of yourself while you're trying? And my mother's not even within the same city. But I will say to you, identify some folks. You may have to pay them. There's something called respite care. And sometimes it's worth it to just be able to set aside $50, $60 to be able to pay somebody to sit with your loved one so you can just go to the movies or the shopping mall. But you need help. You can't do it alone.
Yeah, I think at some point, unfortunately, all of us will be faced with how we care for and take care of an aging parent with health issues. And being prepared for that is important. And to your point, yes, I went through a similar thing. My mom was halfway, well, on the other side of the country, and taking care of yourself is also important as you're caring for your loved one. So thank you for mentioning that. The next question is, someone wants to know how a doctor can navigate around a loved one if they suffer from seizures and need to have a PET scan, and I guess maybe a little bit claustrophobic or have issues being in that situation.
Sure. So let me tell you, there is an MRI scanner that's called an open scan. And so there are a couple of ways. You can get a tranquilizer. The doctor will offer you a tranquilizer as one option. But there are a few places within the Bay Area that have open scans. So the mere fact that you may be claustrophobic doesn't mean that you can never have that test.
Yeah, okay, great. And then the next question is, they're trying to understand in-network and out-of-network, and what is the difference between a medical group and a healthcare system such as Hills Physicians and Sutter Health?
Okay. So I think I can honestly say that a group and in-network are similar. But I can tell you from my own experience that sometimes I see things like Palo Alto Foundation in my bill box, but my care is Sutter, but they're all in network. So I think, the best way for you to know, I also, can receive bills from another hospital, but it's in network. So you just need, you can really go to your insurance website and they will tell you the hospitals, they'll tell you the pharmacies, and they'll tell you the specialists that are in that network. And, if you don't want to plow through all that, then you pick up the phone and when you're interested in the doctor, you call. Do you accept such and such and such? And is this within the network? My primary care doctor is Dr. Susie Smith. And they will, sometimes you do need to do that research in advance so that you are staying within network to keep your costs down.
Great. What about when legal documents are in place and you have to deal with when someone else was wanting to call the shots? I'm not quite sure. Yeah, so what about when legal documents are in place and you have to deal, I guess, with when someone else wants to call the shots? Maybe there's someone else in the family or someone in the, physician or part of the medical team. I'm not quite sure, but.
Okay.
But I would assume if you have power of attorney, perhaps is maybe what this person is alluding to, but then someone else wants to weigh in on
Ah,
making decisions.
ah,
I'm
okay.
making that assumption, but I think that might be what they're talking about.
Okay, well, let's give that answer a stab, and if it's not right, Rhonda, they'll come back to us. So yes, having I've shared with you before that it's really important to have one spokesperson. That's really important. I mean, at least another, one or two. But the whole family coming in wanting to talk about it and make decisions, that's not going to work for any doctor's office or hospital. But doctors will be careful. And when they start to see multiple people coming around trying to make a decision, they will then begin to shut down and start to look for the legal information as well.
Okay.
It is challenging because family members who you haven't seen in a long, long time will often surface when grandma's in the hospital. And don't let grandma own about 6 houses. Then more people will sometimes show up. But, I think it's really important. I think I would just have to say to you, treat that loved one with the same kind of passion, compassion that you can. And people get very stressed when their loved ones are sick, and sometimes they flail out and say and do things that they really don't mean. Try to be as patient as you can, but do what you feel is right, most of all.
And I think this next question depends on the situation, but the person wants to know, do you suggest in case of emergency to call 911 or drive yourself to the hospital, and why? She wants to know for her patients who may be listening.
Okay, so if there's a true emergency, you need to call 911. A true emergency would be shortness of breath, chest pain, uncontrollable bleeding, loss of consciousness, severe abdominal pain, um, even somebody fainting, unless they come to, as they say, and you get them in a chair and they seem fine. But the thing about, first of all, you should not be driving yourself anywhere. And then I don't even encourage that you put that on your friend, because while they're driving and then you collapse in the chair, they can't pull over and take care of you. So it's really best that if it's really an emergency, go ahead and call 911. That's what they're there for. And if you get evaluated in the ER and the ER says you're okay and sends you home, that's okay. You don't need to feel bad about that.
Yeah, just circling back, the person did clarify it's a power of attorney and another family member wants to take over.
Oh, well, the legal will take over there. That conversation should have happened at the time that the POA was created. And, you have an obligation to that loved one that set you, that put your name on that paper as the POA. So it's a tough situation to be in. That's why a lot of times people don't want to do it, because they don't want to deal with the challenges of the family. But kudos to you for accepting it. And I pray that any turbulence will calm down.
Yep, and then we have a few questions in the chat. I'll try to get through as many of them as possible, but how do you navigate a treatment plan with your provider if you are aware that there are other options besides what the primary care or specialist is recommending?
Oh, well, that's just a matter of sitting down and having a conversation and discussing the other options. I mean, um, doctors should know about all the options. And really, we are sort of required to, that's what informed consent is about. That's what I think is challenging. When a doctor comes to me and gives me 6 options, that makes my head swim. I'm like, just give me the 2 top ones. It's too much information. But if you have heard of a different kind of treatment for a problem that you have, just have that conversation with whomever the physician is that's making the recommendation that you do something different. And I promise you, they will either tell you why or give you the pros and cons, or they may back off and say, well, yeah, that is an option.
Yeah.
It may take longer or whatever, but it's your choice.
Yeah. Okay. And then best care is dependent on the ability to pay, is what this person's saying. Many people are uninsured or underinsured. So how can you access the best care when you cannot afford it or when your insurance is not willing to pay for it?
Okay. So, in my opinion, one of the best ways to get the best care is to have an advocate with you. Because at the end of the day, the medicine is the same. So you bring an advocate with you no matter what your insurance is, and you make requests, because a doctor is not going to be able to say, well, that costs too much. I can't order that for you. They can't say that. They may say it's not covered and I can order it, but you may have some medical bills as a result. But it is challenging at times to try to navigate with certain insurances. But I'm going to say that having an advocate with you is going to be what's going to make the biggest difference.
And I know we're going to talk about advocating for yourself and your loved ones in the next session. So hopefully everyone here today can come back and hear more about how to do that and how that can help navigate through this situation. Last question is, quickly, can you explain what continuity of care means?
Sure. Continuity of care is the term that we use, and generally it's related to primary care, so that there is one person that is responsible and knowledgeable about your condition, sort of on a continuum. So you don't go to Dr. Smith for your blood pressure in January and then go to Dr. Jones in March and then go to Dr. Thompson in June. You want to stay with the same person. The same way with cardiology. If you start out with a cardiologist that's, Dr. Thompson, you want to stay. The continuity of the care, it contiguous, keeping up with because your history is very important. And here's the other thing. When you're sick, remember I said this in the beginning, you're being asked to navigate when you're sick. So if you can go to a doctor that already knows you, that already knows your information, and I'll say this in closing, it's so important to see your doctor when you're well. They need to know what your energy's like. They need to know what your personality's like. They need to know that when you step into that office, sometimes you don't even need to talk, because they can look at you and tell something's wrong. But that's only because you have built a relationship up and they know who you are. That's continuity of care as well. So
Great.
stick with, and if you don't like it, then pick a new doctor, but have continuity of care with that doctor.
Great. Thank you so much for your time today. I know we're trying to make sure we get a lot in within the hour, so I really appreciate what you shared today and responding to all the questions. And I know we're talking about maybe having an Ask the Doctor session early next year after we're done with the 5-part series. So hopefully those of you who had questions, didn't get your questions answered relative to this specific topic, we'll have a Q&A session just with Dr. Glenda early next year as we kick off the new year and make our resolutions. So next slide, please. So just a few more things to wrap up. If you want to connect with Dr. Glenda, you can go to her website. Sorry, go to the previous slide. Don't move yet. Yeah, go to her website. You can connect with her on social media, mainly LinkedIn and Facebook, and she also has a blog if you want to follow her and continue to hear her words of wisdom. And also you can get the book. I think someone actually put the link to the book in the chat. So that'll be a good way to reinforce some of the things you're hearing from her in these webinars, and also spend some time going to a deeper level on understanding how to navigate through the healthcare system. Next slide, please. So we want to hear your thoughts about how we did today, and give us feedback on the session so that we can really gauge the impact of what we're sharing and the learning, and then also how we can continuously improve what we're doing to meet your needs. So I'll just leave this up for a few seconds, and you can scan it. I don't know if someone put the link to the survey in the chat, but we'll make sure we cover all the bases, and we do this, we'll do that, and we'll send out a follow-up as well to make sure that you do, we do provide an opportunity for you to provide your feedback. So next slide, please. And just a reminder, if you attend all 5 sessions, you have the opportunity to be entered to win a $100 Visa gift card. And so we'll do the drawing for the lucky winner after the last session, which is on November 21st. That'll be how to participate in decision-making for your care. And then be sure to register for the next 2 sessions. And on the next slide, I'll tell you exactly what they are. Next slide, please. So we have a few more sessions left in this webinar series. In addition to that, we have one of our community conversation series coming up. So session 4 of how to make the healthcare system work better for you is on October 24th. That's how to advocate for yourself and your loved ones. Cocktails and Conversations is an in-community event at Drobe Stogies in Inglewood here in the LA area. Session 5 is on November 21st. Again, that's how to participate in decision-making for your care. We have a Health for Life session, Health Equity Forum, and some member events coming up. So on October 17th, in recognition of Breast Cancer Awareness Month, it's Breast Cancer Clinical Trials in the Black Community. In November, we actually are very honored to have Dr. David Carlisle, who's the president of Charles Drew University, who will be our guest at the November 14th Health Equity Forum. And then we have a few member events coming up on October 3rd. Media advocacy for nonprofits. So that is actually a learning opportunity for our members. And then October 26th, we will have our first ever in-person Black Health Network member networking event in Orange County. So all this information and to register for these events is actually on our website under the events tab, and then in the drop-down menu, current events. Next slide, please. And don't forget to keep up with what we're doing and follow us on social media. Really easy on all our social media platforms. It's at your CBHN, except for LinkedIn, it's California Black Health Network. Please join us in the campaign for Black health equity and support all the work that we're doing, what you saw today, and many other things that we're doing to really advance health equity here for Black Californians. And last slide is just a thank you for being here today. And we hope you enjoyed the conversation and what Dr. Glenda had to share. And we look forward to seeing you next month. So take care. Have a great afternoon. Thank you very much.